Our topic for today, as Dr. Messamore had mentioned, is tricyclic antidepressants. So this is really designed to be a very brief overview, just a reminder, a refresher about this particular class of antidepressant medications. I had grandiose plans initially to look at a bunch of the literature, but I realized that just brushing up on some of the other pieces might be really important. So we're going to look at the pharmacology of the tricyclics, compare a couple of the agents that have some different activity. We're going to look at some of the pharmacokinetic considerations. We'll talk briefly about therapeutic drug monitoring, and then we'll look at a little bit of the evidence, going back to Dr. Messamore's point about why these were so effective. These were the mainstay before we had the SSRIs. So mainly a comparison of the TCAs and the SSRIs. So in looking at our tricyclics, so the reason that their class is the tricyclic antidepressants is their chemical composition actually has the 3 rings. So these medications were developed. They were looking at antihistamines as well as the early development of the antipsychotic medications, and they were looking at treatment for catatonia. So they were making some minor modifications to this particular structure, looking for other appropriate treatments. Imipramine was the first one that had been discovered, and it was found to be going to say a colossal failure. So it wasn't a colossal failure. It was ineffective for the treatment of catatonia, but they noticed that it was beneficial for the treatment of depression. So additional modifications were made to the structure itself to then create some of the other tricyclic antidepressants that we have. So this I actually took from the clinical pharmacology text. And as you can see, the main structure of each of the medications is relatively consistent. It's just some minor modifications on the side chains that really, some slight changes to the rings, but mainly the modifications to the side chains. So subtle differences in the structure that actually create some significant differences in its pharmacologic profile. So how do they work? What do they do? So just as a reminder, tricyclic antidepressants actually were the original SNRIs. So they inhibit the reuptake of both serotonin and norepinephrine. That wasn't discovered right away. Initially, it was looked at to see if they did anything with the monoamine oxidase enzyme. They did not, but they did promote the overall neurotransmission of serotonin and norepinephrine. We're going to focus on 9 drugs in the TCA class because those are the ones that are available in the US. Within them, there is some variability in what the affinities are. So agents such as amitriptyline, clomipramine, they tend to be more serotonergic. Agents like disipramine and imipramine are going to be much more noradrenergic. So even within the class, there is a little bit of variability. Other actions that they have are antagonism at the histamine 1 receptor. This was one of the things they were going after as they were developing this agent. So this is going to give us some of our adverse effects such as sedation and potentially the weight gain. We see antagonism at the alpha-1 adrenergic receptor, which can result in some potentially some fatigue as well as some dizziness and orthostatic hypotension. And then antagonism at the M1 muscarinic receptor. So this will give us a lot of our anticholinergic adverse effects that really are problematic for this class. So your dry mouth, blurred vision, urinary retention, and constipation. The other activity that I think is a little bit underappreciated for the tricyclic antidepressants is that they do block the voltage-sensitive sodium channels. So the voltage-sensitive sodium channels both in the CNS as well as in the heart and cardiovascular system. By blocking these, this is where we can see some of the significant toxicity with this class. So some of the potential seizure activity, as well as arrhythmias that can happen in overdose with the tricyclics. So let's look at the class as a whole. I pondered what we could potentially put in to look at this, and I thought it was helpful to get a refresher on what are the agents that are within this class. So some of them, I think, may be a little bit more familiar than others, but a reminder on what the official indications are, as well as what some of the other uses are for these agents. So we have agents like amitriptyline and nortriptyline. that are cousins, that both have initial indications for depression, but then started to have additional indications for things like neuropathic pain, as well as starting to look at treatment of some conditions where the anticholinergic effects were beneficial. So the functional dyspepsia, some of the irritable bowel syndrome, interstitial cystitis, sialorrhea. So using some of the side effects of these medications, and the doses that they use for those particular indications tend to be much smaller than the doses that we would use for the depression and the anxiety. So with something like amitriptyline, we can go up to 300 milligrams a day, but that's not likely what you're going to see for treatment of some of the neuralgias, for example. Amoxapine, we had talked about briefly. So its treatment for depression has some so all of the additional, for the record, all the additional uses are off-label uses. And it has been used also for irritable bowel syndrome. This one also, because of its relationship with loxapine, that metabolite has some dopaminergic activity as well. So that one makes this a little bit more unique compared to the other agents. Clomipramine, just briefly, again, more serotonergic, but this one seems to have the best evidence for treatment of obsessive compulsive disorder. So a little bit more efficacy consistently for that condition with this particular medication compared to the others. Imipramine is the other agent that does have an approved indication other than depression, and that's for childhood enuresis. Again, probably using some of those traditional side effects for a therapeutic indication. For the remainder of the medications that are there, I would say doxepin tends to be used a little bit more commonly now for insomnia at much lower doses. They can use 1 to 6 milligrams for insomnia, whereas with depression, you'll see 150, 200 milligrams. But the others tended to have just the FDA indication for depression. There's a smattering of use for other conditions, so anxiety disorders, as well as potentially for some neuropathic pain, but for the most part, most of their evidence at this point is for depression. So recognizing that's where we could use all of these particular medications, are there other considerations that we would have if we do utilize them? One of the big ones is they're all prone to drug interactions. So each of the medications within this class are metabolized by the cytochrome P450 system, which means they are susceptible to potentially induction or inhibition of these enzymes. As you can see, 2D6 plays a really prominent role. So for thinking about combination therapy, especially with some of the SSRIs, that could be really problematic, where not only are they both working in the same direction, we could potentially have much higher concentrations than what we would expect just because of the enzyme inhibition. The good news for these, the half-life for most of them tends to be about a day, give or take. There's a handful that do have active metabolites that tend to have much longer half-lives. But with this longer half-life, we will see that it may take about 5 to 7 days for a patient to be at a new steady state. It may take about 2 to 3 weeks for a patient to develop tolerability to side effects that we're going to talk about. And we're probably looking about 4 weeks or more of treatment to be able to see whether or not this medication has been effective. So with that in mind, we, for a number of these agents, there is a bit of a titration so that patients can get up to an appropriate therapeutic dose and be able to tolerate that. So accelerating the dose relatively quickly for something like amitriptyline may result in discontinuation. We could start slowly and slowly titrate. It's going to take some time to get them therapeutic anyways. And that may help with some of the tolerability, and we'll talk about why that's important because those that can stay on it really may benefit from this class of medications. Therapeutic drug monitoring. So I'm mindful of the time I'm watching. That could be a topic unto itself. So each of these medications does have a therapeutic range that has been identified. However, with the therapeutic range, it has been pretty well established that if you have concentrations above the therapeutic range, that patients experience adverse effects. But the consistency of efficacy, so having an effect on rating scales for depression or anxiety, if the serum concentration is within that range, is much more inconsistent. So it's only about 50 to 60% predictive of response. So it's been shown to help if you have it, if you're getting those therapeutic ranges, especially early in treatment, you're much more likely to achieve therapeutic doses, which then results in better outcomes for the patient. But it's not always consistent if you're just randomly checking those that if they're in the range, they're definitely going to have a better response. So it's not as predictive as we would like that to be. But in younger patients, it can be a great additional piece of information so that we can make sure we're using these safely. So I teased about the side effects. This is a major problem with this class of medications. So a number of these are old enough where they don't even give you percentages. So if you look in some of the tertiary resources, it just has the adverse effects listed by organ system, and it doesn't give you how often this happens, just that it's been reported. Those that are most commonly reported are ones that we talked about. So the anticholinergic adverse effects, drowsiness tends to be a problem. The alpha-1 antagonism, so dizziness, potentially orthostasis, those can be issues, as well as some of the serotonergic effects, so initial anxiety, as well as potential nausea or vomiting. A little bit longer term, they can cause weight gain, and in some patients, it may be 10 pounds. It may take a little time to get there, especially if they're nauseous at first, but that may be an adverse effect that initially wasn't a problem, but becomes a problem a little bit later on. On the serious adverse effects standpoint, the cardiac arrhythmias and lower seizure threshold tend to be incredibly problematic, especially for overdose. So this class of agents is very lethal if patients take it in overdose. That was one of the huge advantages of the SSRIs. So it is something we want to keep in mind, especially in patients who may have other comorbidities. So we can monitor this, we can check for any of those arrhythmias, but it is something we'll need to be mindful of. There's some recent literature out looking at the risk of bone fractures in patients who are on tricyclic antidepressants. So there does look like there's an increased risk for fracture, although the risk time frame looks to be early in treatment. So it wasn't incredibly clear if it was just the medication's impact on bone or potentially some of the dizziness, the drowsiness, maybe they're just not as coordinated and more likely to fall. As a class, SSRIs, SNRIs have the suicidal ideation warning, as well as in incidents of having SIADH. So potential hyponatremia, which would be a consideration for some of your patients, those that may be on a bunch of other sodium depleting agents with cardiovascular conditions, or those that are elderly. So definitely a burden. The adverse effects can happen in upwards of 50% of patients, although if they can tolerate it, it can be a big benefit for them. So I just quickly wanted to look at some of the evidence. So I pulled, one is a review and then one specifically looks at the elderly population. So this was a meta-analysis and systematic review that looked at SSRIs versus tricyclic antidepressants. Now, when they pulled, so it's a little bit older, but it did a really nice job of being able to look at actual incidence rates for both of them. And that was why I included it, even though it doesn't have all of the SSRIs. So they included fluoxetine, paroxetine, and sertraline, and then you see the list of TCAs that were comparators for each of the trials. So for this particular review, most of the trials were randomized, they were double blind. They had on average less than 100 patients per group, so they were more moderate sized. But they did follow them, most of them used the Hamilton Depression Rating Scale for their response. So response was a 50% reduction in the HAM-D from baseline to endpoint, or if the Hamilton D scores were either 12 or less or 6 or less. So essentially saying there were very minimal depressive symptoms that were still present. So it was a little bit of a combination of those. When they looked at the intention to treat cohort, it was just under 50%. So just under 50% of patients that were given an SSRI or a TCA had a response, a significant response, so about a 50% reduction. And it was equal between SSRI and tricyclics. When they looked at patients who were able to complete the studies, and the studies ranged anywhere from 6 to about 24 weeks, they found that there were significantly more patients who were given a tricyclic antidepressant that were in the response category. So that 50% reduction or a very small score in the HAM-D. And that was significantly better than the SSRI group. So if the patients can stay on the treatment and continue, it may be very effective for more than 2/3 of those patients. The problem is keeping them on it. So the dropout rates were significantly higher with patients who are on tricyclic antidepressants. And in particular, the adverse effects that so they weren't dropping out because of efficacy, they were dropping out because of tolerability. And the most common adverse effects were not a surprise. So somnolence or drowsiness, dizziness, dry mouth, and constipation. So those adverse effects that can be relatively common with these patients. So definitely effective if we can get them to tolerate it, but what about some of those higher risk groups? So I just pulled one of the trials that looked at elderly patients. So this was a short-term trial, 6 weeks, and it looked at trimipramine versus fluoxetine. This was done in patients who were 60 or older who had a diagnosis of depression. It had the best collection of data, which is why I picked this one, even though this one also a little bit dated. They looked at overall change, and the overall change was similar between the two groups, numerically a little bit better for the trimipramine group, but the response rates again were about 60%. So about 2/3 of those patients were able to have a significant reduction in their HAM-D score. So from 28 to 14, so pretty significant clinically improvement for those patients. And in this population, the discontinuation rates actually were higher in the fluoxetine group than they were in the trimipramine group. So it was fixed dose. They did titrate them up a little bit, but a relatively significant dose of the trimipramine. So even despite that, they were relatively well tolerated. So my take-home point from this was it can still be effective for our elderly patients. We just need to be mindful of whether or not they can tolerate those adverse effects. So quick recap. So tricyclic antidepressants, easy for me to say, they're an effective class of medications, especially for depression. That was the main literature that we looked at. They can be equally effective to a number of the SSRIs, but the side effects is really the main consideration. So if we can go slowly, potentially give it to them at bedtime so they can sleep through some of those adverse effects, that might be more effective. But if they can stay on it and potentially they haven't gotten benefit from other antidepressants, this is a class not to completely write off because it is potentially still an option. With that, I will turn it back over.